first head and neck screening with Advocate, with the South End of Advocate. When was that? August?
It was August, yeah.
On a very hot day, right?
Yes, it was.
And
Yeah.
by the way, I found all that information in my car when I got it was hidden underneath everything, but anyway. So Dr. Max Plitt works out of Sykes and Beverly. He has an office on Western. He is board certified in otolaryngology and head and neck surgery. He is his clinical expertise is an array of expertise. I will list them all. Deviated nasal septum, my husband could use that. Endoscopic sinus surgery, ethanol ablation, general otolaryngology, goiter, Graves' disease, head and neck cancer, hyperparathyroidism, hoarseness, laryngeal surgery, neck mass, parathyroid adenoma, multi-gland disease, parathyroidectomy, radiofrequency ablation of thyroid nodules, remote access thyroid surgery. Can you hear me okay? Okay. Salivary disorders, sleep apnea, which is going to talk about this evening, thyroid nodules, thyroid cancer, thyroidectomy, and tracheostomy management. Did you understand all those words?
Yes.
No, good. Then they will understand your lecture. He went, his education was at Rutgers, New Jersey Medical School. Residency was at Rush University, and we're happy that he stayed here with us. And his fellowship was at Johns Hopkins Hospital in Baltimore, Maryland. So welcome, Dr. Plitt, and we're happy to have you.
Okay, thank you. Okay, can everybody hear me okay? All right. I want to take this opportunity to thank Susan for all her efforts for community outreach. Everything that she does is for you guys. And so I want to give a round of applause for Susan for everything that she's done. So like she mentioned, my name is Max Plitt. I'm an otolaryngologist, head and neck surgeon, which basically means I'm an ENT, and I also do head and neck surgery. That was an exhaustive list of all the things that we do. It's basically everything from here to the upper chest, sometimes into the chest, sometimes into the brain. Our field is very complex. I like to focus on head and neck cancer, big emphasis on thyroid cancer, and my other passion, which is sleep apnea management, which is what I want to talk to you guys about. So today's conversation is going to be about how can we manage sleep apnea from a surgical standpoint, and what is our role as ENTs to help you guys, okay? I have no disclosures, but some of the slides that I used today were provided by the company Inspire, who does one of the things that I will talk about. Okay, learning objectives. What I want you guys to understand is what are the surgical options and non-surgical options to treat sleep apnea. There is no one size fits all. Every patient is different. And so when I see a patient, my job is to understand why CPAP is not working, or can we make CPAP work better? And if CPAP is not working, what are some things we can do to improve quality of sleep in order to improve all the risks associated with sleep apnea? We're going to talk about my clinical approach and other sleep surgeons' clinical approach, and how we look at every single aspect of your throat and your anatomy to determine what is the best treatment course for everybody. And with understanding that, point number 4, multi-level collapse. Not every patient is the same. It's not just remove my tonsils. It's not just I need CPAP. Everybody's airway and body is dynamic and it's different, and it's understanding each level that needs to be addressed. And lastly, and something that I'm proud of, is talking about hypoglossal nerve stimulation and how that has changed the landscape and how we approach sleep apnea moving forward. Okay, so what is obstructive sleep apnea, also known as OSA? It's basically narrowing of the throat and the back of the nose, which narrows the airway tissues while you sleep. All the tissues in the back of the throat above the airway, which is the windpipe, narrow or sometimes even collapse completely. That causes snoring or turbulent airflow. that also causes pauses in breathing. And the name of a pause in breathing at night is called an apnea. So obstructive sleep apnea, narrowing of the throat that causes pauses in breathing. And so areas that we think about is the back of the throat, which is like the soft palate or the back of the tongue, the tonsils, the walls of the throat, the back of the nose and the nasal cavities. All these areas are influencing airflow going into your windpipe. So it's every single structure above your voice box and your windpipe that can be narrowed that will influence your sleep apnea. Without going to technical terms, sleep apnea means that you have decreased quality of sleep. You may have heard of something called REM sleep. This is that deep restorative sleep. If you are not breathing well at night and you have pauses in your breathing at night, that deep quality of sleep is not going to be as long. And that's why patients with sleep apnea, they wake up feeling more tired than even before they went to bed because they're getting poor quality of sleep. This also leads to poor oxygenation and increase in CO2 or carbon dioxide in your bodies. So this is a nice schematic. This is basically what happens. You can see the airflow is poor and all the way on the right side, you can see he's kind of startling awake and waking up. And that's basically what happens multiple times per hour of sleep. So what are some of the signs? By the way, anyone here have sleep apnea? All of you guys? Okay. So you may recognize some of these symptoms. So daytime somnolence. So waking up in the morning and feeling like I am exhausted, or I have to take multiple naps, or falling asleep while driving. These are real things. The number one symptom of sleep apnea, though, is snoring. And that most people who sleep don't notice themselves snoring. It's usually a bed partner, a loved one, or a family member say, hey, you snore. Witnessed apneas. Watching you snore, and then all of a sudden you stop breathing completely for 10 to 15 seconds, and I have to shake you awake. I mean, half of my patients, their family member or bed partner is telling me, like, yeah, sometimes I'm like shaking you awake because I think you're not breathing. These are called witnessed apneas. Fatigue, headaches. I think the other thing that's important is new onset of disease. So all of a sudden, hey, I have bad blood pressure. I've never had a blood pressure issue. Now all of a sudden I have high blood pressure. New onset diabetes, atrial fibrillation. There are studies that show that patients with new onset of atrial fibrillation are 7 times likely to have sleep apnea that's undiagnosed. Okay, all these things are important. So what are some of the risk factors? Well, age plays one of the biggest roles. So the older that we get, the more likely the tissues in the back of the throat are going to narrow and not be as stiff. Okay, so age plays a role. Men tend to get more sleep apnea than women because testosterone can increase the tissues in our throat. Body mass index, this is a powerful risk factor. If your body mass index is greater than 30, increases your likelihood of obstructive sleep apnea. Why? Patients who have larger body mass tend to have more body mass in their neck that narrows their throat. Large neck for the similar reasons. Family history is big. And then all these other, like, what are these fancy words over here? This is basically, is there anything else that could be contributing to their upper airway? Do they have large tonsils? Do they have a palate that's very narrow? Retrorhnachia, which basically means, does their jaw sit really far back, or does their tongue fall really far back? Or do they have a history of Down syndrome or all these unusual disorders? All those things can increase your risk for sleep apnea as well. How do we diagnose it? You guys all know. So you get a sleep study. And that's the fancy word, polysomnography. It's the gold standard, right? You do a sleep study, and what we're looking for is how many times per hour of sleep are you having reduction in your airflow and pauses in your breathing, right? So maybe when you've got your sleep study, they mentioned this thing called AHI. Like, what's AHI? Well, that's your apnea hypopnea index. In essence, it means how many times you stop breathing or have reduction in your airflow divided by how many hours of sleep you got. And then you create a score. And so maybe you guys heard of, like, I had mild sleep apnea. Well, that means that you stop breathing 5 to 15 times per hour of sleep. Moderate sleep apnea is between 15 and 30, and greater than 30 is considered severe. Why do we care about these numbers? Well, mild sleep apnea, it's like you snore and maybe you don't get the best quality of sleep. It doesn't confer the same risks to our body that moderate and severe sleep apnea. You guys may have I've heard of that. And the impacts to our health that we really care about are all of these. So you can see that illustration on the right side, all the things that can be caused by sleep apnea. New onset of high blood pressure, atrial fibrillation we talked about, you're at increased risk for a heart attack if you have sleep apnea. Pulmonary hypertension. When you don't breathe well at night and you retain CO2, it starts putting a strain on the right side of your heart. When you put strain on the right side of your heart, it can increase the blood pressure of the vessels in your lungs. It can also continue to put pressure in your heart, and that heart would want to expand. And when a heart expands, the electrical activity gets disturbed. You can get atrial fibrillation or increase your likelihood of having a heart attack. Metabolic syndrome, diabetes. So basically, if you're not sleeping well, it can increase your risk for diabetes or weight gain or obesity, these kind of things. Increased risk of stroke, this is important. Poor sleep quality, depression, mental health. These are real things. You ever not slept well, maybe had 4 hours of sleep, you feel pretty crummy. Imagine you've been doing that for 5 years straight. You're gonna feel pretty crummy, and there's an increased risk of depression and issues like mental health. And the last line on here, which is the most important, is increased mortality. If you have sleep apnea, moderate to severe sleep apnea, that is not being treated effectively, you will increase your likelihood of dying. It's just that. All right, so what is the gold standard of treatment? And because I'm a surgeon, I talk about surgical options for sleep apnea. I don't want you to think that I don't think CPAP works. It works, but it's not for everybody. The gold standard of treatment for sleep apnea is CPAP, and that's positive airway pressure. How does it work? You guys know, you wear the mask, or it goes over your nose or your nose and mouth, and it provides you with gentle positive pressure. So you're breathing against a little bit of pressure. And what does that do? Keeps those airways that are collapsing nice and open. It improves ventilation, it decreases how much CO2 or carbon dioxide is in our body, and it helps decrease the pressures on that right heart. But CPAP is not for everybody. And so with good use, it's very effective, but we know that the actual adherence to CPAP is variable. It's between 25 to 60%, depending on which studies you're looking at. I will tell you that in my experience, it's probably less than 25. And there's a lot of reasons why, right? It's multifactorial. Why do patients fail CPAP? Well, cost, that's a,
What is considered effective? What should your CPAP, how many a night should you?
Great question. I missed that last line. So CPAP compliance is defined as 4 hours per night, greater than 70% of nights.
But what is the actual number of apneas that you should be less than?
You want to try to correct it to less than 5. If you get
What
it to,
if you can't correct it?
if you can't correct it, then you start talking about other options. Or and then that's why you have a meeting with a sleep medicine specialist and an ENT to identify what is the reason why you're not tolerating CPAP. And that's my next couple slides. Very good question. So CPAP failure is multifactorial. There's a lot of reasons why patients might not tolerate CPAP. Costs, it's inconvenient. You go on a trip, you gotta schlep that stuff all the way to your cruise, and you gotta bring distilled water, and everything's gotta be sterile. Psychological, some patients don't like having something on their face, or anxiety, high pressures. So that's kind of alluding to your question, is if it's so much pressure that it's so uncomfortable to keep your airways open, it might not be a great option, or there's an underlying reason why those pressures are so high. I just don't like it. Ends up on the ground. I hear that probably every single day in clinic. It's like, yeah, that thing, it's just on the ground. Or I'm never using it, no way. And that's okay. But it's
what does that stand for?
CPAP, continuous positive airway pressure. Continuous positive airway pressure.
And that necessarily means this mask.
That is the mask, correct. Great question. So my goal as a sleep surgeon is, how do I make CPAP work better? And that's usually low-hanging fruit for me. And so identifying a reversible cause of high pressures or inability to tolerate CPAP is my number one goal. I don't want to just say like, I'm gonna offer you a surgery, here, you need an implant, you need your tonsils removed. No, how can I make this product that we know is very effective work better for patients? And high pressures equal obstructed airflow. If you need extra pressures to keep that airway opened up, that means that something is blocking that airflow. And most of the time, it's usually from a nasal breathing issue. Okay? There's other issues that can arise as well, but the easiest of the reversible causes is nasal obstruction, inability to breathe well or effectively through the nose. Why is this critical? Because if there's no other options or a patient has a body mass index greater than 40, then really CPAP is the only approved option for you other than weight loss and lifestyle changes. So in order for us to get you treated, we got to make CPAP work better for you. And so here are some examples of why you might have some high pressures. So if you look over here, you may have heard of this term called a deviated septum. Well, all that means is that the bone and cartilage is crooked on the inside of your nose, and that's affecting airflow through the nose. Or you can have a very congested nose, right? So you breathe out of this small slit. Imagine trying to put positive pressure through that nose. That's gonna be pretty hard. Or if you look at that top right corner, those things in the back of the throat, those are huge tonsils, okay? That's low-hanging fruit to figure out what is making CPAP not be effective. And then if you look at that bottom corner, we're looking at something called the lingual tonsils. You probably never heard of lingual tonsils. This is just tonsil tissue that sits on the back of your tongue. Large lingual tonsils can make it so the back of the tongue collapses easily on the backbone. Okay. So reversible causes of nasal obstruction: deviated septum, nasal congestion, chronic sinusitis, nasal polyps, all these kind of things. If we can address those, fix those, then we can get CPAP to work better. What are some reversible causes for what we call throat obstruction? Large tonsils. Tongue obstruction, lingual tonsil hypertrophy, and these are surgical options that could open up the airways more effectively, but to get people to wear CPAP easier and tolerate it better. All right, so I'll give you a patient example. So I had, this is a real patient. So I had a 45-year-old male who had a history of tonsillectomy as a child, severe obstructive sleep apnea. So he stops breathing 50 times per hour. That's almost once a minute now, okay? Body mass index is 42, so there's really not many other surgical options for him, but he had poor tolerance due to too much pressure in the mask. It's like the mask was just like, I can't deal with the pressure. I saw him in clinic and I asked him about his nasal breathing. He goes, oh, I don't breathe it out of my nose. I'm a mouth breather. Well, there you go. So we did a physical exam. He had a horribly deviated septum, I think from maybe a trauma. I don't remember exactly. And he had these large turbinates, which are these airflow structures in the nose. He had tried numerous medications, saline, Flonase, nothing's really helping him. So we talked about kind of a treatment plan and we said, all right, so body mass index, that's obviously a risk factor, weight loss, exercise, lifestyle changes, GLP-1 agonists, which are approved for patients with a BMI greater than 40 or consult to bariatric surgery. All these kind of things that we know can really improve weight and also treat sleep apnea. Or do we try to make CPAP work better for him? And so I elected for, yes, sir.
I want to understand that mask that you wear. You're talking about when it's worn, what it is opening the airflow and it's opening the passage.
Mhm.
Is that strictly from breathing, or are you pumping air into it with a machine, or what?
So it doesn't pump air into your mouth and throat. There are some types of CPAPs that will give you a little bit of pumping of air and a little bit of pressure. That's called BiPAP. That's getting a little technical. But what CPAP is imagine you are wearing a mask and when you're breathing out against a little bit of resistance.
Okay.
And so you imagine if you're breathing with a little resistance, it's going to allow everything to kind of stay open and not collapse. So that's what positive airway pressure means.
So when you have the mask on
Mhm.
through the evening, let's say you're wearing it all 8 hours of sleep,
Right.
you are constantly using the same air repeatedly, in and out. It's not like you're getting new air that.
You are getting new air, it's filtered air in and out, it's exchanging well, but the machine is providing you with pressure. So it gives you pressure to keep the airways open when you breathe in and keep your airways open when you breathe out.
A different question.
Mhm.
I want to understand snoring.
Okay,
When an individual snores, what exactly is making that noise?
Great question.
What is vibrating?
great question. So it could be a lot of areas in the mouth and the throat, okay? Most of the time though, it's the soft palate. If you ever looked at the back of your throat when you say ah, and you see that little thing that's hanging and it kind of looks like a punching bag. So that's called your soft palate and your uvula. And so when you're snoring, you rattle those tissues and you create that. So it's the vibration and the flapping of those tissues. But sometimes it could be also the walls of the throat that are flapping, or it could be the tongue that's narrowing because it's falling backwards. And when you have that reduced airflow, it can rattle the tissues and it can make that sound of snoring.
And when you, earlier, you talked about what, the length of time, the gradation of the loss of time when you are not properly breathing, and you have. How long can you go on if your passage is completely blocked and you're unable to get the air into your lungs? How long can you go on then without a severe problem?
Without CPAP? Without wearing a mask? Is that what you're asking?
Right,
Well, you can go pretty long, but like we talked about, this is not something that immediately is gonna affect you, but over time, it's gonna start putting a strain on your body. And you'll start noticing that untreated sleep apnea will start increasing your blood pressure, your poor sleep quality. You'll feel very tired during the day, you'll fall asleep while driving. And sometimes it'll start really putting a strain on the
but
body.
in an 8 hour of
Yeah.
hours of sleeping.
Oh, all night. Do that all night.
So some individuals can go 8 hours without ever being able to take the air in and have it go.
They are breathing, but it's narrowed airflow and exchange, so it's just not breathing as well. And when it collapses, you stop breathing and you have a pause in your breathing, but your body always tries to wake you up. So when you're like this, the carbon dioxide in your body starts rising. Your oxygen goes down, and then your brain says, oh, it's time to breathe, and it goes, and then it wakes you up. I think, okay, thank you. So yes, what happens is you stop breathing, and it's not like you're gonna suffocate, but it's almost like you're kind of suffocating. And what happens is, as your oxygen goes down, your carbon dioxide goes up, that triggers your brain to breathe, and it will start a startle. It will startle your brain to like, okay, it's time to breathe, and you will all of a sudden wake up and start breathing.
So it never happens that a person actually dies through the night because he was unable to breathe. Oh,
I mean, it could happen. Sometimes patients who have bad sleep apnea can have things like they die in their sleep.
Your spouse punches you.
Or that too. All right. Does that answer all your questions?
I just wake up every 2 hours, it just wakes me up.
Yeah.
It's horrible.
Right.
Yeah, yeah.
Right. Your body will tell you it's time to breathe. And once you're awake, and now remember, it's when you're sleeping, your tissues are most relaxed and want to collapse. But when you're awake, just sit in and you'll be able to breathe.
I think what he's trying to say, while using a CPAP, is there any side effect? Is this what you were trying to say? Like any side effects?
I just want to clearly understand.
Yes.
What the problem is.
Yep. Did I explain that well for you? Perfect. Okay. All right. So getting back to our patient, who wasn't tolerating CPAP, we talked about all options and we actually consented him for something called a septoplasty and a turbinate reduction, which means that crooked nose on the inside, we fix it and we get it so his nose is much more open. That's a 45-minute surgery for me. And patients will go home that same day. But at a 1 month post-op, he was now wearing nasal CPAP greater than 6 hours per night. with decreased pressures. That 45-minute outpatient surgery completely changed his life. He has now more vitality and energy to exercise due to his better sleep, and he lost 40 pounds. So what I talk about with my patients is this concept of the hamster wheel. Maybe you guys know what I'm talking about, where, okay, I'm really tired, I gotta go to bed. But then I go to bed and I don't get good quality of sleep. And then I wake up and I'm now feeling more tired. How am I supposed to exercise and eat properly when I'm so chronically fatigued? And you kind of feel like you're on a hamster wheel, right? And so what I tell my patients is, well, let's try to break that by either getting you good quality of sleep with CPAP or figure out another way. So that you can make those lifestyle changes and you can eat better and just get basically control of your sleep. Right? So this is some actually legit data that shows that nasal surgery and CPAP can really make a difference for patients who don't tolerate CPAP. So about 90% of patients who did not tolerate CPAP were able to use CPAP after nasal surgery. That's a big deal. That's a big deal. So that's why I tell patients is most of the time, if we could just fix your nose, we can get you at least to wear nasal CPAP more effectively or have a combination of options. What are the risks of nasal surgery? And, you know, it's pretty well tolerated. It's the same day surgery, but bleeding or something called a septal perforation, numbness of the teeth, changes in your smell. But for the most part, patients do really well with just simple nasal surgery. And so we call this low-hanging fruit for the sleep surgeon. It should be considered first line of therapy for patients who don't tolerate CPAP. All right. Okay. Question.
What is AHI?
Hmm?
What is AHI?
What is AHI? So AHI is apnea, hypopnea, index. So if you think about it conceptually, it means how many times do you stop breathing at night? Plus, how often do you have reduced airflow at night? You sum that all up and you divide it by how many hours of sleep do you get per night, and that gives you an index score. So you can, if you think about it, okay, so the more I stop breathing per hour of sleep, that must mean that my sleep apnea is more severe. So that's what that index score is.
You have to have a sleep study to determine.
Correct. A sleep study is the gold standard to diagnose. All right, this is a busy slide, but this is basically like what goes on in my brain when I see a sleep apnea patient. All right, so I try to figure out, okay, like what brings them in. If they're saying like, oh, I don't tolerate nasal CPAP, well, can we fix that? And so, do they have nasal obstruction? Okay, do they need something like this or just medical management? Or is it something extranasal? So it's something that's out of their control. Is it they have a narrow palate? Do they need something like dental surgery or palatal surgery? It's like, all right, well, if that's not the issue, then I do a full history and physical exam and I read their most recent sleep study and figure out, okay, well, how severe is your sleep apnea? What things have you tried? And then I do a full physical exam and I'll talk to you guys about like what that looks like. And then I do something called a flexible laryngoscopy. And so in other words, like what I do as an ENT, I put a camera in your nose and your throat. And that allows me to understand your airway better. So I can best figure out, okay, well, what are some things that will help open that airway? Okay. Let's say we get to this part, physical exam, and we realize, okay, you have a body mass index greater than 40. And so you're going to end up over here. How do we get this number better? Is it by improving nasal CPAP, lifestyle changes, GLP-1s? You guys have all heard of like, you know, all those medications now. These are FDA approved now for patients who have sleep apnea with a body mass index greater than 40. So bariatric consult, do we need to consider bariatric surgery or something like combination therapy? It's like, can we use a little nasal CPAP, a little bit of surgery, something else, and combine those things to get you that good quality of sleep and kind of get you off that hamster wheel that we were talking about. Okay. After I do a flexible scope, if a patient's like, okay, I don't want to wear CPAP or it doesn't work for me, what else can we do to figure out what kind of surgery would help me? That's what we do something called a NICE. Okay, and I'll talk about that right now. In a few slides. So what are some non-surgical options for obstructive sleep apnea? I think this is also critical. And it's something that I always talk to my patients about is weight loss, right? So GLP-1 drugs are approved for obstructive sleep apnea, bariatric surgery. So getting that body mass index down to reduce that biggest risk to sleep apnea will pay dividends. Positional therapy. So if you have mild or moderate sleep apnea, you probably have heard of patients or maybe even yourself, you sleep on your side, I don't snore anymore. Well, you're taking gravity out of the equation. Right? If you lay flat on your back, gravity is going to work straight down and push your tongue all the way back to your throat. Okay. All you have to do is sleep on your side, and now gravity's out of the equation. Or sleeping with extra pillows. Or maybe you've seen those things like the beds that kind of like incline pretty significantly. That's positional therapy. What that's doing is it's taking gravity out of the equation. That's a really good option for mild to moderate sleep apnea, not so much for severe. Oral appliance mandibular advancement. So this is basically a mouth guard that you wear that puts your jaw in a better position. Why does that matter? Well, your jaw is where your tongue attaches to. So if you have your jaw that sits further back, your tongue is going to go further back as well. So while wearing something like an oral appliance, which a sleep dentist would create for you, would help to open up those airways at night. This is a non-surgical option. Yeah,
Do you work with sleep dentists?
we do.
Okay, because there are a lot and I have some of these devices,
Okay.
they're not from a sleep dentist.
Okay.
And most of them say do not use if you have sleep apnea. And especially if you're with a full face mask and your mouth is covered, I'm assuming that has something to do with safety issues.
It's a thing with safety. So oral appliance, an oral appliance that's created by a certified sleep medicine doctor is an option for patients with mild to moderate sleep apnea.
See, that's the problem right there. For people with mild to moderate.
Right.
But for those who don't have
Correct.
mild to moderate, it becomes a real challenge.
Now, sometimes we get creative, right? Because not every patient is the same. Sometimes you gotta get creative. We've had patients who go, I like my oral appliance, but I got a severe sleep apnea. Well, why don't we get you to wear the oral appliance, get that airway more open and get nasal CPAP. So combination therapy. You can do multiple things at the same time. And so that has been some options for our patients where we get them an oral appliance that puts that jaw and that tongue in a better position. And it allows them to wear a nasal CPAP more effectively. You can get very creative, and that's why it's partnering with your sleep medicine doctor and ENT to understand where are those areas where you're narrowing. Okay.
In the diagram there, with
Yep.
a circle around it,
Correct.
there's a kind of a yellow item. Is that the thing that is stuck in your mouth?
This is the oral appliance. Right here. So when you're wearing this little yellow device pushes it closes here and it pushes your jaw forward. So it's like this.
So is it are your teeth together or is there?
Your teeth are slightly together, but your jaw is pulled forward. So it's almost like you're giving yourself an underbite.
And there's one on each side of the jaw that
Yep.
It's that thing at the bottom.
It's that thing, it's right here. It's this thing. This is it. Right there.
Okay, what you're calling it an oral?
Oral appliance, or another name is a mandibular advancement device.
Do you wear this with CPAP or you wear?
You can wear it with nasal CPAP. You can do a combination therapy, and that's why working with a sleep medicine doctor and an ENT to figure out what combination is gonna work best for you.
Because you're not supposed to wear it if you have a full face mask.
Correct. It really should be just for with combination with nasal CPAP.
Just only days adult.
And you gotta make sure that you're able to breathe out of your nose well. So like, you gotta keep your mouth kind of closed with an oral appliance, but let's say you're horribly congested. Well, you're gonna have a hard time breathing, right? So you gotta make sure something is open, right? All right, so sometimes in conjunction with improved nasal breathing, nasal CPAP are options, so combination therapy, right? We get creative. So this is basically my full physical exam without going into super detail. This is the part I really care about. All right, I'm looking at the septum, I'm looking at the nose, I'm looking at the palate, the tonsil status, if they're there, and how big are they? if there's crowding in your throat, is your jaw pulled backwards? Do you have a big tongue? Do you have a tongue that's high in your mouth? And then these in-office procedures, and this allows me to really get a very detailed look at the anatomy. Okay, so drug-induced sleep endoscopy. This is where I think we really has shifted in how we treat sleep apnea. So it's like, it's one thing if I see a patient while they're awake. I don't know what you guys do when you sleep, right? And so you do a procedure called drug-induced sleep endoscopy. So what does that mean? We give you a little bit of sedative in an operating room in a controlled setting, and you go to sleep and you start snoring. And then I put a small camera in your nose and your throat. And what I'm looking for is, where is it narrow? And how is it narrow? And that will help me determine, okay, what kind of options could help you? And so we're looking for things like anterior posterior collapse, concentric collapse. Does your airway collapse like a tube, or does it collapse like a clamshell? Looking at the base of the tongue, does your airway open up if I give you a jaw thrust? Would an oral appliance help you, right? And so all those kind of things are tools in our toolkit in order to figure out what kind of combination of things will help you. This is what it actually looks like, all right? So this is a patient of mine, permission of course. So this is a patient of mine who's trying to figure out what other options other than CPAP. So this is them asleep. You see this little black hole right here? That's what they breathe out of that here. This is their tongue. Their tongue is pushing up against the back wall of their throat. That's not very large. So
So
you,
that's closed or is it
it's
open?
almost closed.
That is closed.
And then over here, you see how narrow this is? If this video is on, you see this tissue flapping and causing snoring. This is the soft palate. And so you can see that's pretty narrow up there. You want to see this opened up like this. That's pretty narrow right there. And so that tells us where these areas of collapse are. This little structure right here that kind of looks like a blade. This is called epiglottis. This is the structure that covers your vocal cords every time you swallow. As you can see, this is completely narrowing this area.
And what is the DISE? What does that stand for?
Drug-induced sleep endoscopy.
Say it again.
Drug-induced sleep endoscopy. Okay. All right. So we kind of talked about, like, you got nasal obstruction. You got a symptom on the left, we should probably fix it with something on the right. So then we start talking about, like, all right. So doc, you said, like, okay, there might be some other options for me that is not CPAP. CPAP's not working for me, and I don't want to use it ever again. Well, looking at the throat and how the throat influences sleep apnea is important. So we have these classification schemes that I'm not going to go into too much detail. It basically allows me to look at a patient's throat with their mouth open and determine what's the likelihood that they have sleep apnea. And what it's looking at is a couple things. So it's looking at your tongue position, and it's looking at the size of your tonsils. Right? So we call this the Friedman classification. And so why do we care? So I know what my airway looks like. My airway is like this. So that means when I open my mouth, my tongue sits as low in my mouth as possible. So you can see the whole airway, and my tonsils are the smallest they can possibly be. Right? Now, if you look over here, if someone opens their mouth and you can barely see anything, can't see that soft palate, that uvula, completely blocked. So we call that a level 4. So you can imagine if that person's trying to sleep at night and they can barely breathe out of their mouth because their tongue falls back and blocks their airway, this is a patient who's going to be at high risk for sleep apnea. And so let's look on this side. All these patients have normal tongue positions. This patient has very small tonsils. And you can see the back of the throat. Like, look at all that space there, right? It's a lot of space. I could drive a truck through that. But now look over here. Those are huge tonsils. They're touching. How the heck are you going to be able to breathe through that, right? And so this is another thing that we evaluate as sleep surgeons is, what's your tongue position? What's your tonsil status? Okay. And from there, we can actually come up with a prediction of who are the patients that would benefit from throat surgery. Basically, we take all of these positions, and not to get too detailed, we take these positions and we put you in a stage. Okay, stage 4. Doesn't matter what your tongue position and tonsil status is. If your body mass is greater than 40, throat surgery is not going to help you. Okay. But if you have the smallest tongue and the largest tonsils and a low body mass index, throat surgery might help you. In fact, how much is it going to be able to help you? Well, if you're stage 1, there is probably around a 80% chance that if we did remove your tonsils and do palate surgery or throat surgery, 80% chance that we'd be able to cure your sleep apnea. But that you have to have a very small tongue and very large tonsils.
Doctor,
Yes.
what happens in the slide 4 when you have a big tongue?
Mhm.
What do you do to a patient like that? In that,
We'll get to that. We'll get to that. Great question though. Okay. So throat surgery is an option, right? You may have met people who've had their tonsils removed. I meet adults all the time. They're like, I was told as a kid I need my tonsils removed. And I'm like, okay. And I look in there, I'm like, those are the biggest tonsils I think. And you can imagine if you have large tonsils, you basically got tissue that's blocking your throat all the time. Well, it probably is going to decrease airflow, right? But patient selection is really important. Like we talked about before, if your body mass index is greater than 40, even if you have the largest tonsils, you may not benefit from throat surgery. And why am I very selective about throat surgery? Because it hurts really bad. Okay, and there are risks. But coming together as a team to determine what are some of the options for you would be able to best treat you. Okay. So if you think of, if you have a small tongue or a tongue that sits low in your mouth and large tonsils, you think about throat surgery. Okay? And so this is like an example of throat surgery. I had a patient that I took care of, I think almost 2 weeks ago. So I did this. So as you can see, their airway is starting, like this is what the tonsils removed, but the airway was very blocked like this. And so when you remove the tonsils and you have to stitch everything closed, now look how big their airway is. Okay. This surgery though does have risks, right? It's not a surgery that we love to do because it hurts a lot, right? And so the biggest risk is really significant throat pain, and usually I tell patients about 2 weeks of the worst sore throat if you're in life. And as a surgeon, I like to say that, but if we feel like a patient's going to get good improvement with that, then it's a real thing to talk about. And then of course we care about throat bleeding. These are real risks. Sometimes you can have a little bit of tongue swelling or changes in your taste. But with good patient selection, you may be a candidate for improvement in your sleep apnea with throat surgery. Okay. All right. So you mentioned about what happens if you have a big tongue, right? So that's where we get here. So if you have basic tongue or epiglottis obstruction, all these things that you see over here can treat a big tongue or a tongue that wants to fall backwards. Okay. There's a lot of options for a big tongue. Sometimes patients just have big tongues though. Is there anything else that we can do about it? Well, can we do something about it, or can we put the tongue in a better position? If we could put the tongue in a better position at night, that could be a good option to open up those airways. And so that's when we start talking about hypoglossal nerve stimulation, okay? This basically, when this came out in 2014, this completely changed the game. All right, you may have seen commercials for it, Inspire. What's this? Okay. So this is known as upper airway stimulation. All right. If you're someone who has a big tongue that sits higher in the mouth, you got severe sleep apnea and that CPAP just doesn't work for you, or you just can't make it work. Well, what if we could stimulate the tongue to stick forward? That would open up the back of the throat, right? So that's a good schematic right here. That's what Inspire is. Hypoglossal. We call it. What?
What does this do?
Okay. So hypoglossal nerve stimulator, so Inspire, there's some other products out there, but the hypoglossal nerve stimulator is a device that goes on the nerve that sits right underneath your jaw that is responsible for moving your tongue forward. So that in order for us to talk, we have this nerve called the hypoglossal nerve. And that nerve helps you to stick out your tongue. So what we discovered in 2014 was, well, what if you can stimulate that tongue only when you're breathing at night? To stick out just a little bit. And if it sticks out just a little bit, open up those airways and really make you feel better without having to wear CPAP. And so that's what this device does. There's a lead. It's the lead that goes on the nerve that sits right underneath your jaw. And then there's a little battery pack that goes right on your chest. And when you turn the device on, it coordinates your breathing with stimulating your tongue forward.
So this is not an implant.
This is an implant.
It isn't.
It is an implant.
So in 2014, right after they came out, I guess it was 2000, right after they came out, I was so excited to hear about that. I made an appointment with Rush. I didn't have my sleep study with me, right? So he said, well, how was your sleep apnea? And I said, well, I've been told it's severe. And I've been a iPad user since 1996.
Right.
100% compliance.
Good.
So I was so excited. And then when he got my study, my pressure, he said it's only for lower pressures. Has that changed since 2014?
Yes.
So you can be higher pressure now and it
When
might.
you're saying higher pressure, you mean higher pressure of your BiPAP?
Yes.
Yes. So I'll talk to everybody in a few slides about what are the indications now.
Okay.
Okay. I was at Rush probably when you went to go see him. So I was there from 2015 to 2020, and I know the surgeon that you probably met. So.
Oh, okay, it wasn't you.
No, it wasn't me. I was a resident then. I was training. I was young.
Okay.
All right. So hypoglossal nerve stimulation. So you wear a battery pack here, it gets implanted underneath your skin and your chest. And then there's a nerve lead sensor here. And when you turn the device on, every time you breathe in and out, just stimulates your tongue just slightly forward inside the mouth. And by doing so, it sticks the tongue forward and it also tightens the walls of the throat, which is interesting. Because what we know about the tongue and the muscles that attach to the tongue, when you stick your tongue forward, you're also tightening the muscles of the throat as well. So this is a big deal, because if you can do that at night, you can keep those airways open without having to wear CPAP, okay?
So you have it installed, you wear it all the time, but you only turn it on when you're sleeping.
Correct. Yeah,
And how big is the thing? So there's a wire insert?
yeah, so the battery pack is probably about that big, and it goes right here on your chest underneath your skin. And then there is a wire that goes from there, tunneled underneath the skin. Here, and you have a small cut right here, and you put that little stimulator lead on the nerve. It's a little cuff, it just goes on the nerve, that's it.
Are you able to travel with it?
Yes. In fact, you get a little card, so you can go through TSA, so they'll give you the wand and they're like, oh, I have an implant.
A heart recorder, is that? So I have two wires
Do you
going,
have it on the right side or the left side?
right in the middle, the heart recorder.
Okay, well, so these are all factors that we talked about during your
So
surgery.
you could have two things.
You could have two things, but sometimes, we usually do it on the right side, but sometimes you gotta put that implant on the other side. Remember, you have two nerves that run under here, we just activate one. Okay. All right, this was the landmark paper in 2014, this was the New England Journal of Medicine. You guys have heard of that. And this basically what it showed was, remember that concept of AHI? We took patients with an average of almost 30 AHI down to 9. Okay, with this device, with the properly selected patient. So we went from severe to mild, which is an implant. Patient doesn't have to wear CPAP anymore. That's a big deal. And so this is why this is a landmark paper. And ever since then, it basically has changed the landscape. Okay. So these are some studies that we did like in 2018, basically patients loved it, 94% of patients loved it. Adherence at the final visit, so 5.7 hours per night it was used. And remember, we talked about how compliance with CPAP is greater than 4 hours. For 70% of the night, and so patients were wearing this and using this more than CPAP, okay? 99.5% of patients with this, it's done successfully without any major complications. So we talked about that score. I mean, there's a big difference in these graphs, right? So this is severity for sleep apnea, so severe to mild. That's pretty good. And then this was 2020. So they had already accumulated so many patients from 2014 to 2020, and that data was still pretty strong. All right, so how do we do the surgery? I kind of alluded to it. It's 2 incisions, a small incision underneath the jaw, and a small incision on the upper chest. The surgery now probably takes about half an hour, depending on which surgeon you use. And the device has changed and modified so many times, and now it's really a 30-minute surgery, same day surgery, you go home. So it's a small cut here and a small cut here. And what we're trying to do is right here, we dissect down to find the nerve that controls your tongue. That's called the hypoglossal nerve. We put this little plastic cuff on it, and that has a lead that connects to the battery pack in your chest.
So from the implant to where you're cutting the jaw, there is a wire that
There is a wire.
connecting the two,
Underneath your skin.
and that is. So what do you have, well, to get that wire?
Yeah, you have to tunnel it. Yeah. You have to tunnel it with a little, it's called a wire passer. So you just tunnel it from this incision to this incision by using this kind of passer.
And this operation is covered fully by Medicare?
Yep, we'll get there. Yep, great questions. It is fully covered by all insurance. Patients usually ask like, how long does this battery last? 11 years on average. And then is it MRI compatible, right? You start having to get MRIs for a lot of reasons. And the answer is yes, up to the strength of MRI, 1.5T. And so when you get the implant, they will give you this card that has all that important information. So when you go through TSA and you set up all the alarms, you'd be like, oh, I got my card here. And then of course you'll bring that card anytime you get an MRI, and they'll ask you, do you have metal in your body? And then you have all this paperwork and documentation to help you get the proper MRI. All right. So this is a more detailed look. So this is a small incision. We try to keep it as small as possible, and it's just underneath the jaw. Okay. And then we have this little cut right here. About 3 centimeters. And then this is the size of the implant, and this is how it tunnels underneath the skin. Yeah. So this is what we see in the neck. This is a little muscle that sits right next to your jaw. This is a vein, and this is a nerve. And so what we do is we just put a cuff on that nerve. All right, so what is the criteria now? So the criteria, and this is what we alluded to, so it changed. So when it first came out in 2014, they were very stringent about who can get this. So you have to have a body mass index less than 32. You have to have moderate to severe sleep apnea. And moderate to severe sleep apnea then was 15 to I think 65. Now, because it's so effective, it is now approved for patients with a body mass index less than 40. We were able to increase that because patients, even with a body mass of 40, we're still benefiting from this. It's still for moderate to severe sleep apnea. And so that AHI, so 15 to 100, gotta be between there. And then this is an important thing. You can't have more than 25% of your sleep apnea being central sleep apnea. Central sleep apnea is different than obstructive sleep apnea. It just means that your brain tells your body to stop breathing, as opposed to your airways are narrowing. And you can imagine that if you have central sleep apnea, it's not a throat or an airway problem, it's a brain problem. You have to demonstrate or just say, I don't want to use CPAP or it doesn't work for me. And it used to be you have to demonstrate back in the day, 2014, 2016, it was you have to document that you have tried CPAP for 3 months and it doesn't work. And you have to document poor tolerance. Now you can just say, I don't want to use CPAP. And that's all you have. All I would have to write is, okay, doesn't want to use CPAP or has tried CPAP, that's it. And then remember back to that thing called the drug-induced sleep endoscopy? That's where this comes important. So a drug-induced sleep endoscopy, we have to make sure that this is primarily a tongue problem. Because if we put an implant and you don't have a tongue problem, it's not gonna work for you, right? So what we're looking for in that sleep endoscopy, remember that picture that I showed you? You see how that tongue was narrowing the airway? That is a perfect example of a patient who would benefit. Why? Imagine if that tongue's sticking forward, it's gonna open up that airway better and tighten that throat. Okay? And so that's when, if you are a candidate for this, you would see a sleep surgeon. And we would do a sleep endoscopy. And as long as you check off all the boxes, you're a candidate, and then we just have a discussion. We talk about the risks, all right? This is important, it's covered by all insurances, Medicare, Medicaid, commercial insurances, VA. There might be some subtle requirement differences, but it's covered. So anytime we do this, this is kind of like the patient screening. So the screening is, do you fit criteria for it? Do you want to explore non-CPAP options? Then the next step is, you can see this guy's hand, that's how small the device is. You get a sleep endoscopy, okay? And then if you meet criteria for a sleep endoscopy, then you do the procedure. And then after you're healed, and usually it takes about 6 weeks to heal, fully heal. Once you see me in the office, and it's been 6 weeks, then you go see your sleep doctor, and then they turn it on. And so that first visit is what we call activation, make sure that it works. And it'll feel funny at first, it'll be like, oh, you're turning this thing on and your tongue sticks forward. Once they turn it on, then you start using the device, and you yourself are controlling the intensity, right? And so you just incrementally go up until you find the setting that works best for you. And then once you find that setting that works best for you, then you get a sleep study. And that sleep study will show kind of efficacy, right? You had the implant, now let's see proof of concept. All right. All right, so conclusions. Obstructive sleep apnea is an ear, nose, and throat problem, period. So you should see an ENT if you have sleep apnea to make sure that all of the things are addressed. The gold standard of treatment is positive airway pressure CPAP. It still works, but can we make it work better? And that's my first job as a sleep surgeon is, can I make CPAP work better? There is no one size fits all. Every patient is different. All our bodies are unique and dynamic. And combination therapy can help patients get over any hurdles. And there are surgical options for patients, even the ones with a body mass index greater than 40. We just need to be very precise with our selection criteria. And lastly, upper airway stimulation or the hypoglossal nerve stimulator is a safe and effective option for patients now with a body mass index less than 40. Okay. This is a little bit about me. This is our awesome team. These are my locations. I'm always available. And you guys have any questions?
Well, I'm sorry, we're coming back to your, where were you available? That's.
Oh, yeah, sorry. So I have 2 locations.
In Western.
So I'm at Western. And then my other location is in like Bronzeville, right by McCormick Place.
That's too far to go.
Too far. Okay, so then you can see me at the Western.
Okay.
This is my whole team. If you ever need to make an appointment or anything, just contact us. Yep.
Quick question, I've had sleep study years and years.
Yep.
CPAP. No good, but quick question. If you want to get a sleep study done, do you have to go to the hospital anymore, or do they?
No, so you can do a home sleep study now.
See, I have to go to the hospital.
Yeah, so selection and reasons why you get an in-lab sleep study versus a home sleep study just depends on a lot of factors. If you have any other risk factors,
Okay.
but for the most part, a home sleep study is appropriate for most patients. sometimes a home sleep study may underappreciate how much sleep apnea you actually have, and if you want to get as diagnostic and accurate as a test, you do an in-lab, just because you have more bells and whistles to be able to really diagnose it.
Okay, yeah, 'cause only when I was in, I had trouble sleeping because of all the bells and whistles going
Right,
on.
yeah, and that's the hard part, right? It's like, okay, I'm going to this facility, you're gonna get sleep, and you're gonna do a sleep study. But this place is so weird and foreign, it's uncomfortable, and someone's coming in to check on me every 2 hours. It's like, how is this accurate? How am I supposed to get a good night's sleep? So, yeah, it's not a perfect science. It's not, but home sleep study has been more and more more effective option for.
The implant
Yes,
with the wire. that
Yeah.
Pushes the tongue forward.
yes,
And you just roughly, how, are we talking an eighth of an inch or half an inch or?
the size of the incision,
No, but how much does it push the tongue?
it's different for everybody.
And you control that?
You will control it, and it's not about how much it sticks out, it's about how much stimulation and by like amplitude. And so everybody's different. You might only need a little bit of stimulation. Some patients need a lot more stimulation. Everybody's different.
And general question.
Yes.
What percent of men and women, say over the age of 50, have sleep apnea problems? How common is this?
That's a really good question. You know, I don't have the exact data, but I do know that as we age, is more likely of sleep apnea. So I actually don't know the answer to that. That's a really good one. I would say maybe like 25%. 1 in 4.
There's a ton of people under the age
Yeah.
that have sleep apnea. Yeah, younger people have. If you've had sleep apnea for a long time and you've used, CPAP therapy
Mhm.
or PAP therapy, does your, if you were to do a new sleep study, would it be comparable, just a sleep study, not a titration, would it be comparable to your original sleep study, or would you have an improvement because of your usage of the?
Are you?
Would your AHI become less?
If you get the implant?
No,
Okay.
don't even go implant.
Okay.
Just CPAP in general, PAP in general, apneas. If you use your machine every night.
Mhm.
And you do a sleep study now, 20 years later than your first sleep study, would those sleep studies look the same?
Are you saying, what I'm hearing is, if you use CPAP,
Does it improve?
does it improve?
Yes,
Does it improve your sleep quality without wearing CPAP?
yes,
No.
okay. So if you did one now, it would be comparable to what it would be about the same as I had when I was.
It could be the same or it could be worse. And remember, there's a lot of factors. Has your body mass changed? How much older are you, right? We know that those tissues relax as we age. Right?
Yeah.
These are all real things. They're great questions. Great questions.
So these symptoms are irreversible,
Which symptoms?
like, like it's. Like sleep apnea,
Thank you.
Are you saying,
laziness, if you normal and all that.
you're asking is sleep apnea reversible?
Yeah.
Sleep apnea is reversible, as long as we understand what are the reasons why you have sleep apnea.
Oh.
Could you have that implant and still need CPAP?
Yes,
Okay.
so these are all real risks,
Okay.
right? So you go through all this effort to get an implant, there's no guarantee it's gonna work. But our job as sleep surgeons and sleep medicine doctors is make sure that we are very stringent about our inclusion criteria. Because we want to make sure that it is effective for you. If you don't meet criteria or you're borderline, there's a chance that it might not work for you, right? And even if you do fit criteria, there are situations that I've heard of other surgeons who, like, the patient was a perfect candidate, got the device, and it just didn't work. And that's where it gets creative. I know some patients who had Inspire and were an oral appliance. Because what they found out was, it wasn't the tongue moving, it was the jaw position. So doing both worked for the patient. So that's why sleep apnea is complex. There is no one size fits all.
How far out are your appointments?
Probably looking at about 4 months out. But if you meet with your PCP and you're really interested and we might be able to squeeze you in. I always have openings here and there.
So CPAP, I know as I've tried it over your full face, I can't see it.
Yeah.
There's a smaller one, did you say, the nasal one?
Yeah, it's called a nasal pillow or a nasal CPAP. Really? So nasal CPAP is pretty effective and it has a lower kind of facial profile because it's not like you feel like you're suffocating. It just goes over the nose like this. But remember, a nasal CPAP can only work if you can breathe through your nose really well. And so our goal is, okay, let's say you're not tolerating CPAP. I want you to wear nasal CPAP and I want it to be more effective, whether or not you need a surgery or you just need some medicines for your nose.
Doctor?
Yes.
So if a person wearing a mask,
Yeah.
they can also use a nasal one?
Yes. Yeah, there's many types of CPAP masks to fit patients, their facial structure, but also their needs. Sometimes patients don't tolerate nasal CPAP and have to wear a full face mask and like it better.
And you have to keep your mouth shut. You have to just keep your mouth shut during sleep naturally. Or with a chin strap or something, if you only use a nasal, your
If
mouth has to
the
stay.
air will escape.
Your mouth has to stay.
And
shut.
Take your mouth shut.
Well, no.
It's gotta be able to keep your mouth closed. I don't like patients, using mouth tape.
Yeah.
I have or had deviates, septum surgery, I hated that, that was awful.
Okay.
But since the last 5 years, I've had 3 falls on my face,
Mm.
so my nose is broken.
So
I
sorry.
don't wanna, my age, I don't wanna do,
Okay.
surgery at that, but I've always had this sleep apnea too.
Right.
It's not just because of the broken nose.
Right.
So I have to get the nose fixed before I can do it.
Not necessarily. I think making an appointment with an ENT or a sleep medicine doctor to understand like, what are your goals? What have you tried? And doing a full breakdown.
That's all I've ever tried is sprays.
It really depends.
Okay, all right.
Yeah.
One more question.
Yeah.
My mask is probably like 15, 20 years old.
Uh-huh.
I used it for like a month and
Yeah.
couldn't get it. Are they as bad as it was back then? And Mr. Snuffleupagus with this long thing?
I think it's gotten better. I think nasal CPAP is definitely much more comfortable and a lower profile. The other thing is the full face masks, they're definitely much more comfortable now. I actually, when I was in residency, probably like 2020, and that was still like in 2020, like they actually made us like wear a mask to try it. And I was like,
I think every doctor
Yeah.
and every, technician who fits, for
Right.
those who have to do that.
absolutely. To answer your question, the masks are better and they are humidified now and sometimes even are warming. And so sometimes patients are like, oh, my mouth is so dry, you can actually get a humidified CPAP. Sometimes you can get like warm humidified CPAP. And so they're definitely a lot more comfortable nowadays. But I mean, it's not perfect, but
Do you have any connection to companies that make like ResMed and all?
No.
I wish you did.
no, I don't. I'm just a surgeon.
When do you do the sleep test in your office or? You?
No, so because I'm part of Advocate, I work with the Advocate Sleep Medicine team. So we have a fully integrated sleep medicine team that's able to get you plugged in, do sleep studies, sometimes even do virtual visits, and then determine if you need a home sleep study or an in-lab, and then they'll get you set up with CPAP. If it doesn't work for you or you don't want to use CPAP, then they'll make the appropriate referrals. So I use them, I send my patients back to them and vice versa. Yes.
Years ago, I successfully mounted an oral device that was different than what you were showing me in the slide.
Mhm.
Do they still do, I don't know what to call it, but it was like a rubber bit, that you put into your mouth, similar to the device that rimmed the teeth, and this screen. but it had a bubble that was outside the lips. And
Interesting.
you push your tongue into it and it pulls the tongue forward.
Hmm. You know, I've never heard of that one.
It worked very well.
Good. Good. The ones that I have the most experience with are, there is a really great group in Chicago and Chicagoland. They're called Midwest Sleep Dental. Their exclusive mission is to create effective oral appliances for sleep apnea, period. They don't clean teeth, they don't pull teeth, they don't do, all they do is oral appliance. Midwest Sleep Dental. And so they will create and usually it's covered by insurance, usually, especially for Medicare. They will create a well-fitted, like indestructible oral appliance. Not like, there's a lot, I'm sure you've heard, like, there's all these like things online or Amazon, like the Zipa or the Z-Med or all these other like oral appliances where like you use it once and like falls apart. This is like industrial grade, like plastic, like you could literally run it over it with your car, it's not gonna break. And they are adjusted and created specifically for your mouth and your teeth. So that's what we call a like sleep medicine dental approved.
But you need a prescription from you first if you go there.
Yeah, so, and this is what we do, so like if you were to see Advocate Sleep Medicine and they think like, oh, you'd be a good candidate for an oral appliance, they would just put the referral in and vice versa, like if I saw you and I'm like, oh, oral appliance, like I could put the referral in.
You would also be doing the whole,
Evaluation,
yes.
yes, right,
Doctor,
yes.
once you see a patient and you prescribe a CPAP for, you know. After patients start using it.
Mhm.
How does the relationship stays after that, you know?
Are you talking about like a relationship with me or a relationship with like a sleep medicine doctor?
Are you sleep medicine doctor? Or-
So I'm an ENT.
ENT.
I'm an ENT and surgeon, so I usually don't prescribe CPAP. I usually see patients who have been prescribed CPAP to see, are there any things that we can work on together to make CPAP work better, or are there non-CPAP options? But I never prescribe CPAP because I have a sleep medicine doctor who's gonna be controlling that for you. Okay. You wouldn't want a surgeon messing with you.
Doctor, why do we yawn, you know? What is the reason, you know?
What's the reason why we yawn?
Extreme yawning is
Extreme
somebody
yawn.
who's like-
Extreme yawning is probably a sign that you're tired.
Yeah.
Yeah.
I get that all the time. you know?
I yawn all day long.
Yeah,
Have you done medicine type?
but
Or to the.
you know, I don't know, and I know that we've tried to figure it out and we're not actually sure, but it could be something with like getting oxygen to your brain. But there's no complete understanding as to why we yawn.
Okay, thank you.
And,
Yeah, very good.
Excellent.
Yeah, thank you. I'm very-
You really did a great job.
Thank you.
Very great.
Like while wearing the